Hello, and welcome to the Alabama Public Health Training Network. I'm Bill Kennedy with the Alabama Department of Public Health, and thank you for joining us today for our program, Self-Care in Challenging Times, Care for the Caregiver in the Age of COVID-19. If you have a question about anything being discussed today, please call or email during our broadcast. Or for those that are watching Facebook Live, you're welcome to send a message through Facebook Live. The phone number and email address are on our screen now and will appear again later in the program. Also, the handouts and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it does qualify for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today, James L. Sacco. Jim, as we know him, has been with us. This is our fourth presentation on the COVID-19 pandemic that we've been dealing with and working with specifically with some special populations. And so welcome, Jim. I know you have a lot of important information to cover today, so let's go ahead and get started with your presentation.
Great. Bill, thank you very much. Welcome, everybody. Good morning from Asheville, North Carolina. As Bill said, I've had a long relationship with the Department of Public Health in Alabama and have been a consultant to a number of states around the Southeast. I'm currently based in Asheville, North Carolina, beautiful Asheville, North Carolina, and am delighted to be part of this conversation. As Bill said, this is a fourth in a series of 4 on COVID-19 and psychosocial implications. And we, as he said, we did a little work the last few times on special populations. This time I want us all to draw a deep breath and think about the emotional toll that COVID is having on consumers and ourselves. I think we see so much in the medical literature about the epidemiological implications and the clinical treatment. I've been really struck by the number of things I've read that talk about COVID as a mental health crisis. And in particular, there was a New York Times article in June that I'll reference later. There was an article in Esquire magazine, both of which kind of talked about COVID as a mental health disaster. And the hard thing is we don't have hard science. I'm going to give you some data, but as Bill and I were talking before we went live, we just don't have peer-reviewed journal studies yet on what's the emotional impact been and what are the implications. So what I try to do in this course is piece together kind of what we know so far about the psychosocial impact, make some inference based on previous natural disasters, and then really invite us to think about the stress of being on the front line, and that is people nursing, social work on the front line. I know we've got a lot of public health people who've been deployed to various response activities. I know we've got public health employees that are on the front line calling people, doing testing and contact tracing. And, I, for one, just in addition to experiencing this myself, I just think that for all of us, there are multiple levels, including just being alive in the age of COVID-19, and then added the fact that many of us are caregivers. So there's our goal for the time. We're going to identify stressors for us and think about better self-care strategies. Really, the heart of this thing is at the end of the video conference, I hope people will leave with 1 or 2 ideas about how you can improve your self-care practices, that if this works at the end of the day, we will be committed to getting a little better at physical, emotional, spiritual self-care. That's my hope. So our objectives, we're going to talk about barriers, talk about some of the unique stressors in the age of COVID-19, really particularly the emotional, psychosocial stressors associated. We want to kind of just have you brainstorm. If we were in a small classroom, I'd do a group activity where we shout out. Unfortunately, we have some limitations on the video conference, so we'll kind of be hopefully making some comments through the web and through phone and email. I'd love to hear people's input about stressors and about self-care strategies. This last bullet is something that I'm particularly interested in, which is cultivating, for us and for consumers, cultivating issues of resiliency, those factors that help people survive natural disasters. I think given the impact and how long we've been going through COVID-19, and unfortunately, I think how long we probably are going to continue, I think thinking about how people survive natural disasters and trauma is an important thing we can all be in conversation about. So just to get your own wheels spinning, how are you doing today? And what's something you can do to help in this challenging time? Just kind of think about, again, if you're willing to send anything you found helpful on the email or the phone, that would be super helpful. So thoughts about life in the age of COVID-19. It's about grief and anxiety, about COVID-19 and traumatic experiences, sort of how I'm starting to think of this as a traumatic event, and then again, how we go about and take care of ourselves. So what I've got on the screen here are some symptoms of COVID-19 grief, some things we know about grief. I've had this conversation many times, and I think what's unique about our current day and age is that, in fact, we don't have models for the kind of grief that we're experiencing in the age of COVID-19. The models that we have sort of think about a defined loss that happens. I think about Kubler-Ross's work, kind of a defined loss, and how in light of that defined loss, we'd have a grief response that's sort of predictable and goes through the phases that have been described. I think part of what's unique about COVID-19 is there aren't models. I mean, we can look at studies of what's happened in other natural disasters. We can look at what's happened in other infectious disease pandemics. But what we know is the models don't really address where we are now, and that's 20 weeks in. Again, I was talking to Bill earlier. You know, there's some literature on sort of what the after effects of SARS were, what the after effects of H1N1, but in fact, we don't have any models for anything like what we're dealing with, and certainly not as we think about the remaining months, or heaven forbid, years that we'll be going through this. So sadness and hopelessness obviously are expected reactions. I think what's also really important, and some of us may have experienced this, a kind of anger or agitation, frustration. Obviously, there's a great deal of anxiety associated, and whenever people experience loss of control, you could expect that anger and impatience. I find myself periodically in really strange situations, being a bit impatient at home with people I care about. We all know we shouldn't, but it's fairly easy to lose our temper and to experience frustration sort of being vented in inappropriate ways, and certainly I'll admit to that. One of the things that comes up in grief is fear and guilt and uncertainty. I think you know, there's an interesting thing about the contagion that we're dealing with, where people who have made mistakes, air quotes, come down with COVID-19. There are a number of interviews of people who've contracted COVID-19 who are interviewed in their hospital, and they say, I did a dumb thing. We've got some deathbed interviews where people say, I should have taken this more seriously. And the tragedy of contracting COVID, the tragedy of there being a death from COVID is that much worse when part of your reaction is blaming oneself. And I guess just for all of us to kind of say collectively, we're all doing the best we can, unless you're going to stay home, get your groceries delivered, and keep your door locked until there's a vaccine. We're all making these very difficult decisions about how to cope with this, who to see, what to do, and we've got some black and white in terms of guidance, but there's a whole lot that we don't know. So I think a lot of people, as part of grief, are experiencing weight loss or weight gain. Those are typical measures. Unfortunately, my pattern tends to be the latter. I found myself with some unhealthy habits that could lead to weight gain. I'm trying to manage that. And this last bullet seems really interesting to me, that there's some executive function challenges associated with grief. I early on in the epidemic, a local therapist does video blog on her Facebook, and I stumbled on it, and she talked about difficulty as part of grief, difficulty just with sort of why did I come in, even more those of us of a certain age, even more why did I come in the room, where am I headed? And I just had experience a day or two before of getting lost. I was headed out to do an errand, and I sort of got on the wrong road to come back, and I was sort of like thinking, well, what is wrong with me? I've driven this road many times. And it was interesting when she talked about executive functioning. I thought, this is about grief. This is about my reaction, this kind of underlying grief that I think many of us are experiencing. So what's happening in terms of anxiety, I think, has to be included as part of this conversation. We're dealing with something that, while we know some things about the way to contain COVID-19, there's a whole lot that we don't know. I think, especially of that first wave of fear for many of us, that was late March, early April, when the seriousness, the number of cases grew, the seriousness of the clinical complications. And again, while we CDC and other World Health Organization, other researchers have provided guidance on how you get COVID and how you avoid COVID, that in fact there remains an anxiety about what we don't know. People will still say, well, maybe the jury's not in. One of the recent findings, I think, as well, people who said, well, once you have it, you have it, and you're antibody positive and you're okay. And then this conversation about even for people who have fairly mild cases, the long-term clinical implications. And so this business of the unknown, I mentioned earlier, loss of control. I'm someone who likes to keep my environment in my control and keep things in my affairs in my control. And, there are things we can do in terms of what's known about COVID-19, wearing masks and washing hands. All those things continue to be the best practice, but there's a lot that we can't control. And certainly when we talk about the political response, the larger public health response, that this loss of control is enormous. Sense of what's going on for those who are still seeing patients, and certainly those who are responding directly in medical settings, social work settings. There's something about being on the front line of this that we need to name as being especially challenging. Many of us are still working from home and have the luxury of being contained in our workplace, but there are emergency responders, frontline healthcare workers, nurses, physicians, PAs, social workers, other folks who are going to work in medical, social service settings, who are interacting with the public, interacting with infected people. One of the things Bill and I talked about was the number of people in public health that are doing contact tracing, and what he hears from people whose detail has been to call strangers up all day long and talk about where they possibly could have exposed to someone. Again, good public health practice, but the toll of making those calls and day in and day out, and what that does to our emotional well-being as people who are concerned about others. So the last bullet here just reminds us that at the end of the day, we live in an age where one mistake could be potentially fatal. And again, we know that increases as people, the risk continues for people with pre-existing conditions. That risk continues with people who compromised immune system. That risk increases with people who have potentially older people with that cluster of other pre-existing conditions. As we look at who dies from COVID, it is people with pre-existing conditions. People who are elderly, people who are immune compromised are most vulnerable. We certainly know there are other young, previously healthy adults, but it's just much less likely. So a mistake could mean, a fatal disease. One of the things. Yes, sir.
I just wanted to, sorry to interrupt you, but
no.
You're talking about anxiety, and one of the other things that I've talked to folks that are making decisions, and they have that weight of, do I open back up? Do I not open back up? Do I go on a trip? Do I set up a class? Do I, and the anxiety they have over whether it's a good decision to open back the daycare or to start church again, or to start classes again, or we had plans this summer to go to camp or to go to some sort of summer activity, and there's the pressure to open, and then there's the pressure not to open, and they're in the middle, and so that anxiety and that weight of trying to make the right decision and please everybody is impossible, certainly. But trying to balance that and
build the grief associated. Part of my reading and preparing for this talk was, we're grieving those things that we've had to give up, grieving our summer vacation, grieving our family reunion, grieving, the things that we would have done. I put a post on my Facebook and I said, hey, if you were free to travel anywhere, where do you wish you were going? And, hundreds of people chimed in, just all my Facebook friends. I want to go to France. I want to go visit my cousin, just the awareness that what we've given up and in the change. And the anxiety of policymaking is real. And parents, we talked about this before we went live, the idea that parents want to do what's best for their kids. And I think most people agree that having kids in a classroom with professional teachers is ideal. Are people ready for school to open up? And what do you do about work? And what do we do when that first child comes down with COVID-19 is part of the anxiety everyone lives with. And you're right, Bill, when we open up and how to open up safely, do we go out? I find myself going out in baby steps. I sort of went from lockdown to meeting people outside and didn't do any restaurants. And now I've been to a couple patios, but I still don't want to sit in no crowded restaurant, no bar. I was saying to a buddy last week, when on earth are we going to go to a concert or go sit in a crowded movie theater? I wouldn't go sit in no movie theater to save my life, but I miss the movies. Netflix is not the movies. And so, for all of us, the age of uncertainty. Thank you. Part of what I wanted to introduce is the idea that our reaction to COVID-19, the implications of COVID-19 are a traumatic event. And part of what I was struck by in preparing for this is there's very, very little peer review published random control hard science on what we're going through. The hard science is just not in yet. So we're trying to find our way and describe what this means and the implications about this. But I did look back in preparing for this talk, and there are a number of journal articles that have been written about previous pandemics, SARS, H1N1, Ebola, and those again fairly limited outbreaks, certainly in terms of time, limited and contained fairly quickly. But in multiple cases, as we look at those previous infectious agents causing a kind of natural disaster, rates of PTSD approaching 30 and 40%. And so, again, what's going to happen in terms of COVID-19 and how many of us are impacted by the trauma is an enormous unknown. But I think it's something we've got to prepare for. And I think certainly on the social work side, for us start to think about sort of how do we respond to traumatic events? You know, what do we know about good trauma response? And then because good trauma response mitigates PTSD. And then again, part of that, how do we build resilience factors? So just to name it, this life-threatening condition, if you think about sort of historical trauma, childhood trauma, natural disasters, these elements of COVID-19 tie into things that people who've experienced trauma, again, natural disaster, early childhood experience, adverse childhood experiences, fear of the unknown, feeling powerlessness, and sort of you've got this really scary event, you're powerless to do anything about it. And the prolonged anxiety associated with this fight or flight response. Part of what I think is going on, and Bill, you talked about opening up and when to open up. Part of what I think we're talking about is just the neurology of the human body, the human brain. So as we get in this, I've got to protect, I've got to defend myself. A caveman posture, the dinosaurs are coming for me and my family, sort of learned response. There's all sort of physiological reactions that happen in the body. Well, for protective reasons, we tense up the blood vessels constrict, so our heart has to pump faster. That gets you pumped up and ready to fight the dinosaur there and to protect your family or whatever adaptive thing we had to do as cavemen. Now in the age of COVID, we're in this kind of heightened response all the time. And this sense of heightened anxiety at the grocery, when we pass people, when we read the newspaper, you know, how many times a day, depending on how far out in public you are, how much anxiety you bring, how many times during the day does your body experience this psychological, physiological tensing associated with fight or flight? The body's natural instinct is to encourage release. Like it makes sense. Some part of us is saying, I want to release. So when we look at people that say, oh, heck with it, I'm being polite here. Oh, heck with it, I'm going to go ahead and go out to a restaurant. I'm going to go ahead and go on vacation anyway. You look at people, I think about Memorial Day. And I think most people in terms of the response, the history of COVID-19 in our country are going to look at Memorial Day as a turning point. Everybody was starting to be tired of COVID. States were saying open up. And there are just multiple pictures of Memorial Day. People relax social distancing, people in large groups. You know, you want to say, oh, those were people making bad decisions or young people. I think there's also something about the neurology of fight or flight. People were so tired of being on guard that the ability to let down and disarm is part of what's led to risk taking. Again, the social distancing that makes perfect sense from public health containment. We absolutely need to maintain social distance and wear masks and do all those healthy things. But there's a way that particularly for people that are already prone to depression, who maybe have issues of loneliness anyway, this feeling of being trapped in the house, increased feelings of isolation. We know as we look at factors related to anxiety and depression, census studies sort of inserted some questions about anxiety and depression. 35% of Americans in April and May, they did several thousand people. They inserted questions about the emotional response, and 40% said, yeah, I've got symptoms related to anxiety. Almost a third, maybe 30%, had symptoms associated with major depressive disorder. And so there is something going on about being isolated that, again, we're just seeing the tip of the iceberg about, but that I think is going to have long-term implications for us. Bill, let me catch my breath. Any questions come in? Any comment come in from people viewing?
Sorry, had to unmute there. I did have one comment that was made. It said telling me to one decision could be fatal. Created anxiety as well. So, in one of your comments earlier,
absolutely. No, absolutely. I mean, that's again, we don't think about that consciously. We don't talk about it. I'm aware of it when I go to a store. And the normal experience of running to Lowe's for supplies. I shouldn't plug a particular store. Running to a home improvement store to get a thing, or running to the grocery store for things you need is a normal thing. Shouldn't be a reaction, but if you think about it, a mistake at the grocery store has the potential to be fatal. Most people are social distancing, but a couple weeks ago I was somewhere. Luckily, I had a mask. My fellow shopper had a mask, but I'm trying to not be ugly. But she had to reach in and get tomatoes in front of me and come within less than 2 feet, maybe 2 feet away. And I said something. I said, we're supposed to maintain 6 feet. And again, we were both masked, and it's more than 2 weeks ago. So I lived through but it's just shopping for tomatoes. It shouldn't be life-threatening, but that was a case where she clearly really breached my personal space. And if both of us had not been masked, I mean, again, I don't know her, but I am over 60. I'm hoping that's a surprise to people viewing on video, but I'm over 60. And so the fact is that puts me in a risk category. Here's someone I've never seen in my life getting within 2 feet of me. It should just be a normal trip to the grocery store.
And to just go a little further, the fear of possibly passing something on to a loved one. Absolutely. I talked to a friend last night, and he said he hasn't seen his grandparents, and because he's afraid of passing something on to them. And we're going on 4 months now since he saw him. It's just, but he's afraid, and he would, if he were to pass something on to him, he just doesn't feel like he could live with himself. Yeah. If he were to cause their demise or something. So.
Well, and Bill, we talked about it earlier. How full are hospital beds in Montgomery? How full are hospital beds? How full are ICU beds in the state of Alabama? Much of the Southeast. We continue to have hot spots in Florida, Arizona. And if I'm an ICU nurse, do I feel, my grandparents obviously, but what precautions about going home? If I'm a nurse in a hospital that's full, ICU beds that are full, state of Mississippi, turning people away from emergency room beds. Earlier this week, I saw Jackson, Mississippi, the University Hospital was saying, we are full, we cannot take another patient. So if you're in that kind of setting, yeah. So, I think what's important is we look at what's showing up in our clients. A part of what I wanted to invite in this conversation was again, we're focused on understanding the prevention measures, which is important. I just think as we start to try to do some prevention of trauma, we start to maybe look at how grief is showing up, look at those symptoms of grief, and then start to name it for our consumers, to start to say, hey, we are giving up a lot here in the age of COVID-19. There's a lot that we used to do that we can't do, and it's sad. we've experienced a loss as a result. What signs of anxiety do you see in yourself and consumers? And again, we want to sort of name the emotion and start to build coping tools. Try to give people tools to manage. The end of the day, when clients, patients have had behavioral health problems addressed in the age of COVID, dealt with successfully, they're more likely to be able to get through this. Our goal is to help as many people, to build resilience so as many people can get through COVID-19 without lasting behavioral health implications. Linking back to what we talked about 4 weeks ago, all of this also helps you prevent and screen for and address substance use disorder. It's not a leap to say all these pre-existing things make staying sober harder for people that are in recovery, make the possibility of misuse of substances. I was did a workshop and in the chat box, this is probably early in June, in the chat box the participant was just sort of musing out loud that he's got a colleague who just talks about in sort of jokey terms, but talks pretty regularly about over drinking as a result of COVID. And it may just be a joke, but he kind of put out to the group, should I address as a concern? And my response was, yeah, I think if it's just fun, if it's just being funny, your colleague can say, oh, isn't it fun to talk about how much wine I drink? But I think to say, to go back and say, given all this emotional stuff, you're talking about your use of alcohol, do you have a concern about it? Is it problematic? Just inviting people to make that connection between these underlying issues and the potential for other problems. So how do we cope with grief? I think that's at the heart of this thing, as I said, sort of ways that we cope with the difficult emotions helps us help patients, helps us all help ourselves. The literature on grief is really clear. The most important thing is feel your feelings and get supported. I always say, when I'm working with clients, I always say grief is something that moves through us if we allow it. We can feel like we get stuck in it, like we'll never get through it. But in fact, feelings of grief are largely transitory. When we feel the feelings, you allow the feelings to happen. My belief is we get into trouble when we try to not feel the feelings. I'll own that for myself. When I try to avoid sadness by eating or shopping or whatever, or just plain old avoidance, that those maladaptive coping things don't help me get any better, and in fact get in the way of my grief response. So feeling feelings is always at the start of this. The last of this is getting support, sort of old school kind of, if you feel the feelings, you talk about the feelings with people care about you. That's the line there. Feelings, sharing your journey with people that care about you is how we get through grief, how we survive grief. It's also important that there's no one way to grieve. One of the criticisms of Elizabeth Kubler-Ross is the stages of grief, and people start to say, well, how long am I going to be in denial, and when will I get into bargaining, as if it were linear or something that you could set a watch to. There's nothing, my own experience is there's nothing about grief that's linear, and having lost both my parents in the last few years, what I find is there's a grief associated with their passing, but then here's Mother's Day and Father's Day, and here's sort of predictable times maybe where you'd feel sad, and then there's random, I wish I could call my daddy and tell my daddy that story, kinds of emotions. And so it is just, grief is a process, and I think especially in the age of COVID, Bill talked about what we've all given up, the freedoms we've given, freedom to travel. I get a magazine on travel destinations, some kind of travel magazine. I was looking through, I just got mad, like, well, no, I'm not going to go on that cruise, and no, I'm never going to go to that hotel. No, never going to get out of this darn house again. Just kind of, that's a loss. Travel is travel. If you're someone that values travel, I think most of us are giving up something that we value: contact with people, friends, hobbies, aspects of our lifestyle. And so that's the last bullet there in the middle, that grief will be unique to us. I also know people who are weathering COVID-19 well. I've got a buddy who says, people keep calling, asking me how I'm doing, and I'm really doing okay. That's fantastic. As long as that honest check-in, I'm doing okay, is really in place. So all of those important things, and then physical, emotional, spiritual self-care. The ways to cope with grief are to do the thing. Usually they're the things we know how to do. My own experience is when I'm in a difficult spot, I know what I'm supposed to do, and my planning process that we'll get to in a little while is reminding me of things that I know how to do. This last bullet is important for us and for consumers to recognize grief as a short-term, transitory, emotional process related to a loss, and again, usually time limited, versus depression, which is, especially if unchecked, longer lasting. I always describe it as a cloud that sort of settles over and doesn't go anywhere. And different, again, that grief is something we move through. Depression, something that sort of hovers over us, and that's much more difficult, especially major depression. That's much more difficult for us to recover from. What we do is I think, as we're talking to people, we recognize symptoms of depression. We do screening for depression. If you're trying to say, well, this person is just dealing with normal stressors associated with COVID-19, and is particularly anybody who had a previous history of depression, screening for depression, good old PHQ-9, allows us to kind of flag people who need additional support. Bill, you want to weigh in?
I did. I just wanted to ask this. Somebody that's grieving, can that grief move into depression? Is that something that you see, or are they just totally separate?
No, I think grief can be. It's about, to me, it's about the timing, Bill. It's about how long. When I think about so depression, you'll see the feelings of grief. We talked about sadness, hopefulness. There's absolutely a similarity. I get concerned, Bill, when we talk about sadness and hopefulness without any abating. With grief, especially after the acute phase, you'd expect waves and ups and downs, and you expect better days and worse days. Most of us who've had a loss, better days and worse days. I think I get concerned when we talk about there just aren't good days, and the things we know how to do in self-care don't elevate my mood. And again, one thing that's always a flag to me, Bill, I learned early in my training, anybody who's had symptoms more than a year that look like depression, that person, I really raise a flag, because now there are physiological, neurological changes that have happened. And so the difference as I see it is, again, grief tends to come, you're going to have some similarity, but it comes and goes. It's able to be impacted by self-care practices and support, whatever else. Whereas the feelings of depression, it's the sadness and hopefulness that lingers. It's intractable with those coping tools. And again, from my perspective, if it's been more than a year, that's particularly where I start to talk about the chemical changes that accompany depression, the idea that that individual probably needs to be evaluated for psychotropic medication. I just think if you've had depression more than a year, I think it's essential that you consult a psychiatrist and say, should this person be evaluated for medication because of the neurology of depression?
You know, I know that we've talked about grief in all four of the presentations, and And we traditionally kind of think of grief as the loss of an individual, somebody that we love. But I know that we've talked about grief in this context with COVID-19 being the loss of, whether it's a job, whether it's being able to do something, celebrating birthdays, celebrating weddings, celebrating the opportunity to go on vacation or go somewhere that you go every year, whether it's to the beach or to the mountains or on some sort of a trip or even grieving just being able to see the individuals that you love.
Couldn't hold a graduation, couldn't hold a senior prom, couldn't do the High School Musical at the end of all those losses.
All that time that was put in working on certain things, baseball seasons, football seasons, volleyball, all of those athletic events. And I think it's funny, certainly the children, the students have missed out on that, but oftentimes it's the parents, who have invested in that child and over the years and to get to a point where they're, ready to watch that baseball game or to see that final volleyball match or golf tournament, whatever it might be.
And there's that, Bill. And then the part of the reason I keep inviting us to think about it is I do feel there's a kind of collective grief that as I listen to people who are kind of thinking about trying to understand the enormity of this, the idea that we're in a kind of communal grief. I mean, I guess what I'd have you do is think about when you're watching the nightly news or wherever you get your news and they do the case reports and they talk about the number of deaths, and there's a kind of wave of sadness that I experience, a wave of pessimism that I experienced lately. That's a kind of grief that again defies sort of I'm missing seeing my grandparents. That's this much stranger, harder to name grief, but that I think is part of this experience. And when the book is written on COVID, journal articles, 2 years, 5 years, I think they're going to have to talk about a kind of collective grieving that we're going through, and again, how we're all coping.
Just to go a little further, this week, the SWAC conference announced that they were delaying some of the football games. And so we have here in Montgomery a Turkey Day Classic. And so we've been talking in our office upstairs that this year the Turkey Day Classic may not happen. And what do we do on Thanksgiving? And it's a tradition. It's something that's always done and been a part of. And as we see football seasons, certainly down in the South, a lot of our social engagements are based on football season.
You bet. What are Alabama fans going to do every Saturday this fall? I mean, talk about grief. Not to mention the expense of Alabama season tickets. You know what I'm talking about. But yeah, absolutely. And I had a discussion. Somebody said my kids are going to want to do Halloween. How on earth am I going to send my children out to strangers' house? Again, if we're in this for the long haul, what about football season? What about going back to school? What about musical, recitals, whatever else? And what about holidays? I don't want to go. I don't want to sit in this basement with 40 people at Thanksgiving, having them breathe on me and breathe on my plate of food. I mean, I love Thanksgiving as much as the next guy, but I'm going to do it differently this year, I think.
Or if you go even further, Black Friday. I mean, there's a lot of folks who a tradition is standing in line to get that inexpensive TV and
face to face with 100 people.
Right.
Bill, you gonna find me online. You sure not gonna find me at no Best Buy with people breathing down my neck this year. I'll risk whatever else. But yeah, absolutely. So again, we talk about anxiety. We know that cognitive and behavioral approaches are the way to approach self-care. So for us, for patients, sort of watching our self-talk, sort of if the tape in my head is this thing is terrible, it's going to kill everybody, there's nothing we can do about it, it's never going to end, and I can get there. I promise I can go there. Versus, you know what? Most human history, these things have ended. There are a lot of smart scientists working on this thing. There are a lot of people doing healthy things to prevent COVID-19. So again, trying to reframe the pessimism, the emotion there. Stop scaring yourself. Trying to find some reassurance, that internal reassurance. There's a look at resiliency factors from trauma. People who survive trauma have some capacity, internal reassurance. I can find, rubbing my belly here, finding some internal ways to soothe myself so that I can get through this challenging time. Looking at doing something different in your head. And then the last bullet, changing the channel. Like when I get stuck on a thing, and what I think is important is sometimes just literally saying, I'm not going to keep thinking about that. I'm going to switch to something else. And certainly with the television, I've done, golly, probably 25, 30 webinars since COVID started. And frequently I start with that question, how are you doing and what are your coping skills? Because I just think, reviewing our coping skills is always helpful. And one of the things I hear frequently is people are deciding how much news to take in. And I don't have an answer for you. I don't have an answer for your consumers, but what I know from my own experience is when I take in too much information, I get anxious and sad and overwhelmed and feelings that don't help me. So other things to do kind of behaviorally, remember that keeping physical distance is not the same as isolation. And so one of the things I found pretty early on is particularly when we were like many people, we really locked down for 4 weeks, 6 weeks. Man, it was really, did not go anywhere, didn't interact with anybody in our little bubble here. And what I found is I needed to see faces. And so even though we weren't even at that point doing outside picnics or not doing much of that at all, but I found just sort of the social media tools, the distance tools that help us do audio calls or web-based calls were enormously important to feel connected. And so kind of trying to stay connected in that way. Just trying to stay connected by helping other people. One of the things that I've had people describe is remembering to reach out to people who are on their own, church members who sort of say, well, we still keep a list of parishioners who need help, and we check on them. We still are doing virtual prayer partner things. And so when we get outside of ourselves, part of how we can cope is sometimes just not getting in my own self, but taking a minute to say, can I make a meal for someone? Can I do errands for someone? Can I just call and check in on someone that I know lives alone? And I think for many of us, there have been times when that helps us get out of our self-absorption. The science is clear about how people cope with anxiety. Exercise is an extraordinary important part of that. And there are limitations if your gym isn't open, if you're not comfortable going to a gym. I've got a little mini home gym set up back here just to try to keep some of the pounds off during COVID-19. But what's important is exercise releases endorphins and norepinephrine, other physiological tools to lower anxiety and prevent depression. And so particularly cardiovascular exercise, we're talking about brisk walking. It doesn't have to be running a marathon. Brisk walking, 30 minutes helps release some of those good chemicals. And again, as I poll people in my webinars, what are you doing? Trying to stay active seems to be an important coping tool for people. Eating right, again, we're healthcare workers. We know what we're supposed to do. Trying to limit unhealthy foods. I'm someone whose emotions leads to unhealthy eating, and so trying to keep the chips at bay, keeping some of the sweet treats out of the way, or I can eat from an emotional place, which is not healthy. So avoiding all the overs, the ways of coping that aren't helpful, too much alcohol, sex. I say gaming. I think it's important that people enjoy those tools if they like. There's also this conversation about compulsive gaming. I think we're mostly talking about kids and young adults. I guess there's older adults that do this. A real age thing about that. But what I'm talking about is releases that are healthy. A little shopping is fine, a little alcohol, but that when misused, the overindulgence can contribute and can trigger a kind of compulsive response. I worked with a clinical supervisor a long time ago who talked about the heart of compulsive behavior is something that initially helped make the problem better. So a drink or two helped me manage my anxiety, but the hallmark of compulsion is we continued to do it even as the positive effect of that behavior decreased. And so avoiding the possibility of compulsive behavior. Sleep hygiene just refers to the habits about what healthy people do. What that means, if you've had sleep disturbance, you've had this conversation. If you haven't, it starts with caffeine intake. First question: how much caffeine? What time of day? That sort of chocolate, any stimulants are going to affect your ability to sleep. And so tracking those, making sure that you manage the limit or eliminate, depending on how severe your sleep disturbance is. Doing the things to get yourself ready for sleep. So it's amount of caffeine and stimulants during the day, but then as you start to move into sleep, creating rituals where you turn off your screen. Best practice is turn off screens an hour before you go to bed. There's something neurologically about the screen that makes any screen that makes us more likely to stay awake. So if you're someone having trouble with sleeping, watch your caffeine, screens off an hour before. Create a ritual where you move into relaxation, whether that's a warm bath or some milk, or certainly there's some physiology about chemicals in milk, amino acids in milk that produce sleep. But sort of creating an hour before, creating a ritual, your ritual that allows you to move into sleep. Those are all suggestions for how people having sleep disturbance and improve their sleep habits. And then, as I said, just how much news are you willing to take in? Bill, let me check in. Do we have any calls or emails that we should check in on?
We actually do. We have 2 comments that have come in. Can you hear me?
Yes, sir.
The first one is thanks for validating so many of my thoughts and concerns for my friends, my family, myself. Your comments are helping me put some things I haven't understood into perspective, and you're giving me a way to be helpful to others. Thank you so much for some practical information.
That's great.
And then the second comment we had, great information. I just lost my aunt to COVID on Monday. It's been extremely difficult not being able to be together as a family for support, not being able to be with our loved ones when she passed away, and not being able to attend the funeral. Such an emotional time right now, but thank you for this webcast.
Wow. Yeah, we haven't even talked about that, Bill. The idea that loved ones are in the hospital without us, that people are dying without any contact. I have a girlfriend whose grandmother contracted COVID and no one could go. And, you know, these stories of people, the nurse holding the phone up to people's head and missing of the ritual. Bill and I talked about football and vacations, but the ritual of funeral, how we need to come together, how much that ritual helps us. And so I'm glad this is helpful. Those comments touch me, and just the intensity of what it means when people are isolated and sick or dying, or we lose people in an age of physical distancing. And again, there's no model for us that says sort of here are the predictable reactions to losing a parent and not being able to be there and not having a funeral and no one coming together. I mean, I know, Bill, your people bring how many cakes to a wake now? Must be what, 12 or 15 cakes at every wake or funeral?
You don't get in the door unless you bring a covered dish.
You better bring a cake.
Don't even show up if you don't have some chocolate cake or some fried chicken. I mean, we're going to talk about you.
Right. Yeah, that's right. And please don't bring a healthy salad with vinaigrette. Nobody cares for that at your funeral.
Jim, I do have another comment that's just come in. It says, yes, helping others has been so important to me right now because I have all control of what's going on around me. At least that's something I feel like I have some control, is helping others. And certainly, that happens in a lot of different ways, whether it's just calling and checking on folks, or whether it's, providing meals, whether it's being able to run to the grocery store.
Doing a grocery run and leave it on people's steps. You can leave it on people's steps if they're being safe. But yeah, for me, Bill, it gets me out of my selfishness. I think not to label it, but all these emotions, I just get preoccupied with myself. What about me? And oh, poor me. I'm my losses and me. And just say, no, I'm gonna make a meal for someone. I'm gonna do whatever else I think helps us. I'm glad this is helpful to people.
One other thing is you're talking about exercise and being able to go to the gym and those kinds of things. I'm hearing folks that are doing Zoom exercise. There's some accountability. You're getting to work out with the people that you normally work out with or exercise with or do yoga with.
Yeah.
So you still have some social pieces of it. Yeah. But the accountability, and you're helping others, and they're helping you. So.
And I need that, because I know that YouTube is full of plug in and do Pilates yourself or do yoga. I'm not going to do it. I need an instructor or either friend saying, hey, we're going to Zoom at whatever else. And I hate to plug one of the online platforms that seems to be one of the most popular, but yeah, sort of finding ways to both get physical exercise and some of the social stuff that used to happen when you went to the gym or went to your Zumba class or whatever. So I've said earlier, if this is a kind of free-floating trauma, then what can we do about it? I think there's something about learning from people who survive trauma. And again, studies of particularly natural disasters and even some studies that look at childhood traumatic events, what the pattern seems to be is traumatic event happens, natural disaster or abuse in the family, whatever happened, and that the traumatic event happened, and about a third of people statistically could be anticipated to go on to develop serious psychological problems, specifically, most likely post-traumatic stress disorder, PTSD. Same in the military, veterans exposed to the stimulus, the traumatic stimulus, about a third go on to develop symptoms of PTSD. What that means is 2/3 of people don't experience the same stimulus and don't go on to develop lasting psychological harm. And in the PTSD literature, there's this conversation about resiliency. In looking at this, I went back to some researchers at Duke. The scale is called Connor-Davidson scale. It's an online resource, and particularly for those of you who working in mental health or who deal with trauma, particularly immediately post-trauma, trying to have conversations about which of these resiliency factors. They outline 10 resiliency factors that are, when they look at people, 2/3 of people who seemed to survive without lasting damage, these are the factors that seem to be traits of people that survive trauma without lasting complications. People with social support and connectedness. I've talked about that when I talked about grief, but again, a traumatic event happens, I've got social support. Action-oriented coping means I feel like I can do something about it. This is the reason why many of us are cleaning out closets and alphabetizing our spices. And I don't know, one day, a couple weeks ago, I decided to scrub out the bottom of my fridge. There's a whole lot I can't control, but buddy, I was going to get that junk out of my produce drawer. Anybody else got a produce drawer that needs a good soak? But that sense of I can take action. The opposite of that is a kind of, it sort of feeds into the helplessness. And so where you feel like you can take action, not necessarily even in terms of the perpetrator of the trauma, but take action, and action-oriented style in terms of coping makes it more likely you'll weather the storm. Self-efficacy is a term that is much broader than just self-esteem. People with high levels of self-efficacy have an internal sense of, I can do this thing, I can beat this thing. So the task is go back to a scary place where you had a traumatic event. Let's go back to that. People in New Orleans went back to, after coastal Mississippi, went back to or go back to Alabama, go back to where there was a tornado. That sense of, I can do that thing, and seeing the trauma, the impact of a natural disaster, saying we can rebuild, we're gonna get through this, I can do that thing. That's what people with high levels of self-efficacy say. People with poor self-efficacy say, there's nothing I can do about it. Things just happen, and I don't have any sense that I can do anything about it. That relates to the idea of mastery. That sort of, so again, as we think about coping with COVID, developing self-efficacy, building that internal dialogue, I think by pointing out previous successes. With clients, I'd say, you've been through a whole lot, and look at all the coping skills you've got. It's horrible that you've lost someone, but you've been able to weather difficult times. To the person with the comment who was experiencing a loss, I'd say, I'm so sorry for your loss, and it's great that you're able to share about that. And look at the previous things you've been able to do with your life, and make a list of your successes, and make a list of the things that you'd survived, and all those things tell me it's likely you're going to be able to get through this. So feel your feelings, get some support, practice self-care. Those are all ways that we as helpers help build self-efficacy. People who survive have a sense of purpose and or a spiritual life. I think those are connected. There's a popular book, The Purpose-Driven Life. I don't even know, other than I know it speaks to kind of acting on your values and your spiritual beliefs, doing work, and whether that's work for your job or work in the world that you do, based on kind of acting out on your values. And so cultivating that. I talking about the experience. The last reminder is people that survive trauma seek out help when they need it. And so again, this whole conversation, what's normal grief, what's normal anxiety, I think just really being able to check in with people and sort of ask, how are you doing at coping? How much impact is this having on your life? How long-standing are these feelings? So in other words, I see a client who's got anxiety or grief or appears to have some of the symptoms of trauma that are concerning. How long has it been? How severe is it impacting your functioning? Maybe pulling out my screening tools for depression, anxiety, and if need be, to give people permission to say it's okay to get professional help. And again, some of the people who survive trauma survive because they reach out and get pastoral care, clinical social work, nod to the psychologist, behavioral health treatment for the problem that exists. Bill, let me catch my breath. Anything else come in, questions or other comment?
No additional comments. Again, I think folks are just finding this very informative. So I appreciate what you're doing there, Jim.
My pleasure. I think we're all trying to find our way, aren't we?
We are. A couple of things that did come to mind with me, though, is I've got some friends that are not comfortable going back to church yet. And church is very limited, a little different now. A lot of spacing going on. But even those that aren't comfortable with that, I have a friend who watches it live on Facebook. But she gets up with her family, they get dressed, they drive to the church and sit in the parking lot.
Right.
Because they want the getting up and going, but they're not comfortable going inside yet. And so I thought that was interesting and a great way to deal with it. And certainly I'm seeing churches that are doing the parking lot with the pastor speaking, and it's coming through the radio, and they're going to church and trying to get some normalcy, but yet aren't comfortable yet. Or maybe have some health issues that prevent them from wanting to go inside and potentially be exposed.
Yeah. Again, but what you're saying is that question of how do we stay connected? How do we stay connected to the people that matter, to the rituals that matter, and not risk contagiin? And I think
it gives them some control. It gives them some control too.
You bet. I'm gonna go there and keep going. Exactly. I'm gonna keep doing the thing. I love the idea of getting in your Sunday clothes to sit in the parking lot. But if that's the way you maintain that important social connection, if that's the way you maintain connection, I think that's essential. Same thing you talked about. This is from a previous thing. I'm going to go through these. We talked about those previously in the other call. Let me go ahead. I'm going to advance all right, I want to move forward because we're a little shorter on time than I'd like, and this is a topic that I think is extremely important that I want to make sure we cover. One of the things that we've learned as we study trauma and people that survive trauma is the risk to people who are providing care to people who are trauma survivors, and the phenomenon of people who are providing services and take on symptoms of what our consumers are experiencing is called secondary trauma. And this is grief, and this is loss, but it's even more than that. It's the idea, and again, if COVID-19 is a traumatic event, if COVID-19 is something that that is like a natural disaster, and we're going to be working with people who are trauma survivors, then this last sentence is really important for helping professionals. The act of listening to traumatic stories may take on a toll that compromises our functioning and gets in the way of our quality of life. And so this is not just sort of how to enjoy online Zumba, but I really want to drive this home. And I think about, we've got, I know anecdotally of 2 or 3 suicides of healthcare workers that were on the front line of COVID. Again, I think that's the tip of the iceberg in terms of secondary trauma. I watched the medical director, I think it was the medical director, I talked about the story of the University of Mississippi Hospital, I'm sorry, I don't remember the exact, the University of Mississippi Hospital, whatever the name hospital, but their medical director was there. This dude was exhausted. This dude was wiped out. And just as he talked about the place being full of COVID patients in the ICU, and his exhaustion just kind of came through. And so again, we've got these couple suicides that several of us have heard about, but what the impact of people on the front line, and then again, coupled with our own personal losses, our own personal stressors, I just think that self-care is a good idea. And if we think about this as a potentially traumatic event, it's essential that that we start to be aware of signs of secondary trauma, and that we respond with the appropriate intensity depending on the situation. So physical signs of secondary trauma, these are the things that people who are experiencing other people's trauma, again, back to Bill's example of nurses on the front line, people doing contact tracing, telling people they've been exposed, being with their anxiety day in and day out. These are things to look for, sort of, am I having any of these things? And if you are, I think to flag these and say, wow, these are not just inconvenient, but these are related to what I'm doing day in and day out as part of responding to COVID, and I need to pay attention. More issues there: rash, a skin rash, teeth grinding, cardiac events, emotional signs of secondary trauma. Again, not surprising. Again, I talked about the images I saw, and I think about how many interviews I've seen with healthcare providers on the front line. You know, the nightly news goes to a COVID unit, or one of the news channels goes to a COVID unit and says, "How are you doing?" or "Tell us about what it's like on the front line." People seem completely physically, emotionally exhausted, just down to their bone marrow. And so I think watching for those signs, watching for depression, anxiety, listening for hopelessness, again, in your own life, in the lives of people that you care about, again, especially people that are really in the thick of the response. And then the sort of natural defense mechanism of being calloused. You know, what happens when we're experiencing this pain, this next to the last bullet says we're feeling less empathy. It's not a bad person. Again, that's a protective mechanism. What it is the psyche saying, I'm so worn out, I've got so much injury as a result of what I'm hearing, that it's affecting my ability to feel compassion. And again, from a logical it's the logical response to an emotional reaction, and it impedes our ability. And the last thing down there, resentment. I'm resentful of people calling, resentful of whatever else. Dread of working on certain issues. As you look at this list, the word burnout, symptoms of burnout come to mind. I think it's really important. It feels like burnout. I mean, it looks like burnout, some of this, but burnout is less primarily about the emotional reaction to hearing other people's reaction to trauma. And that's the distinction that burnout can be work-life balance and a supervisor and pace of work and document. There's a whole lot of potential causes. Secondary trauma is really honed in on these emotional reactions: hypersensitivity, difficulty leaving work at work, all of these related to our interaction with people in traumatic times and our own reaction to trauma. Behavioral signs here, we talked about avoiding drugs and alcohol, shopping, gaming, irritability, watching too much to escape, not logging into whatever else, but too much escapism. I'm all about escaping. I'd be mortified if anybody see my Netflix bill or my whatever TV bill. But we know when we're using television as an unhealthy escape. We know when we're using screen time. My own experiences, there's some mindless internet places I go. We've all been there, where you just watching stupid stories, whatever kind of dumb escapist stuff, but it's too long and it's too much, and it's getting in the way of living your life. And so there's a way of managing sort of, it's fun to watch this movie or this television show, but now I've just zoned out. That's the term I would use. I've just zoned out as a way to avoid emotion. That's when it becomes problematic. And the isolating down there, obviously, is important. Last set of signs of behavioral impact of trauma: difficulty with decision making, feeling like you're faking it or not good at your job, relationship problems, thinking about quitting. Not always a bad job, not a bad idea. If you're sometimes fantasizing about leaving is an escape from emotions that I need to be dealing with. That sort of, I wish I could get out of here, is really a harbinger of an inner knowing, like something is going on you need to address. And sometimes it's a very healthy, constructive kind of release from, this is not the healthy thing to do. And I give everybody permission to say, this is not the right job or the right time for me. And so I just think it's super important. If you are someone saying, I'm not sure about this or that, that you sort of weigh in. Is this reactive or short term? or am I just really done doing this thing, being in this place? And then all the workplace junk. Bill, let me check in. Anything that's come in on the Facebook or calls that I should tackle?
Nothing at the time, Jim.
Okay, great. I'm gonna take us home, Bill. We got a few more, and then I'll do one last round of questions. So, part of what I always invite people to do in this workshop is sort of ask this question: how important is it for me to practice my self-care habits? What's important? I want to say that I think what's super important is figuring out where you were at before COVID ever started. If your battery was already half full and COVID started, that's really important. If you are underlying sort of an anxious person before there was COVID, you're going to be really having that much more anxiety now than you would have. So where were you at before COVID? How severe is your current stress? What impact is it having on your day-to-day functioning at work, at home, your relationships? What's your current stress level? One of the first question I ask, 1 to 10, how are you doing? If you're an 8 or a 9, you're doing okay, you're coping. If you're 2 or 3, that says to me you better get serious about self-care. You better make it a priority. You better call someone and say, wow, that video conference at Alabama Department of Public Health made me think I better do something about it. I say call someone because for me, the accountability of saying out loud to someone, this dude talked about something and I really see myself needing to get healthier. I talked about my stressors. There's something about saying it out loud and getting outside of ourselves that's helpful. That's that last bullet. Who can help me sort of with some accountability? Who can help me hear my stress? I think it's important that we think about these barriers. Sort of what do consumers bring to get inside? What do systems do that impact self-care? What are internal barriers to self-care? That as part of this journey, we kind of say, we're not going to take time to do this, but you do some inventory. What barriers exist, like clients are demanding, like the system isn't responsive to my need for work-life balance, like I'm an unhealthy helper is a great internal one. I want to talk about that as we start to step into this. Sort of, are you someone who's saving the world? Are you someone who is that person who's always taking care of others, doesn't set limits? Many of us learn to be nurses and social workers in our family. There's a blessing in that. We learn good things about caring for others. And for some of us, we learn what I call the unhealthy helping. Sort of, I'm going to save the world and I am invincible. And that's the take off your leotard. Sometimes I can pretend that I'm Superman. I know nurses who act like they're Wonder Woman when underneath they're struggling, they're uncertain, but it's this kind of professional persona. The story I always tell my friend Joanne talked about her early nurses training. And the first patient she lost, 20-year-old nurse, 21-year-old kid. And she said that she lost a patient and she went down to the stairwell of the hospital to cry alone because she knew good nurses weren't supposed to cry. I hope that we're teaching nurses and physicians and social workers something different in 2020, but the idea that we are pretending to not be vulnerable, not allow our emotion, and down in that stairwell by ourselves, crying, anxious, sad, is really something important for us to address so that we can say, I deserve taking care of myself. And then understand your caregiver fatigue. That's at work and at home. I always say we're the people that the church calls to go door to door, and the Heart Fund calls, and our neighbors call for whatever, our cousins call for bail money. We're the helpers, a lot of us. And so sort of saying I'm exhausted for some of us is the start of getting better. I really hope people leave this conversation saying, I'm going to take better care of myself. I'm going to do the things I need to do. And I also really want to challenge people. Can you create a different climate at work? Can you say, that person that says, well, I didn't break for lunch, say, you really need to do that. Or I kept getting emails from people at 11 o'clock at night. I'm working on a project. There's a woman that's emailing every night, 11, 12 o'clock at night. it's not my job, but somebody needs to say to her, girl, you don't need to be on no email at 11 o'clock at night. That's not what healthy people do. And so that climate at work then extends to the culture at home. And we say to everybody in the house, we're going to all eat right and practice the things that people do. So again, just as part of winding up, sort of, what do we know about what people do to take care of themselves? What are your plans to take care of yourself? I want to just ask the question, what do you do to take care of your physical well-being? What tools do you know? Do you eat right? Do you sleep? Do you get your nails done? Do you get your massage? Do you exercise? Fruits and vegetables. Limit saturated fat, sodium. What are you doing to care for your emotional well-being? Sort of all the good practices I talked about and talking about coping with grief and loss. What's your spiritual practice? You know, again, for a lot of us, it's what do I go back to? This can certainly be the structure of a church and other formal religion. A lot of people I know also talk about meditation and reading and nature and other ways they connect to the Great Spirit. You know, sort of what habits have you done in the past? What things do you need to reintegrate? Every time I teach this workshop, I think I come back to the reminder of the Serenity Prayer, that my challenge to everybody who's been part of this is there's some part of COVID you can't fix. You know, the incidence of people who are sick is out there. The incidence of how much disease is out there, bad choices that people may make about prevention, all that is out there. But part of how we cope with challenging times is the courage to change the things we can, like our self-care habits, like doing things that we know move us in the direction of health, like tracking unhealthy habits and saying, no, I don't need that second glass of wine. You know who you are? You don't need that second glass of wine every night, right? And so sort of monitoring and saying, that's different than self-care. That's not an effective self-care habit. Bill, last call for any question or comment. Do you have anything else that people have asked?
Nothing else has come in, Jim, but one of the things that you said there at the end that I thought was encouraging, one of the things that we've been saying is there's only so much you can do. You know, at what point do you kind of have to either let it go or turn it over? And so I liked how you ended there, and you can't change everything. Yeah. Do we wish we could just wave a wand and COVID-19 would go away? Yes, definitely.
And we can.
But it's here. It's here. With that said, I do want to talk about a couple of things that we have coming up. This does conclude our 4-part series. If you'd like to watch some of the previous programs, you're welcome to go to our website, to our distance learning page, and you'll find those programs there. Our Facebook page where you can find them. With that said, I'm excited to announce that we've got a 2-part series coming up in August on ethical issues during COVID-19. August 5th and August 14th, we will again have those on our distance learning on our satellite, as well as through our Facebook live page. Continuing education again has been approved for nurses and social workers for this program. I do want to remind you to receive credit. You must watch the entire program, then complete and return the sign-in sheet and evaluation. The address is at the bottom of the sign-in sheet as to where you need to turn in your sign-in sheet and evaluation. Jim, again, thank you so much for being here. Thank you for watching. Please remember that you can refer back to this training and resources anytime on demand. And so with that said, please have a great day. Thank you.